Good morning, everyone. Thanks, Dr. Manaf, Dr. Mashira for inviting. Thanks, Dr. Nathwani. We start. It's a big challenge to talk about local experience because actually we don't have many published experience, but many, I'm sure we have many experience to establish antimicrobial stewardship programs in health facilities, clinics, and hospitals, and we are not really different from other parts of the world where we should have antimicrobial stewardship programs to reduce the resistance of antimicrobials. And the overuse and misuse of antimicrobial medicines is a key drivers of antimicrobial resistance and growing global health problems. Antimicrobial stewardship programs can address inappropriate use of antimicrobials and help slow the spread of antimicrobial resistance through systems-level approach supported by policy structures and interventions. Comprehensive antimicrobial stewardship programs have demonstrated success in reducing inappropriate antimicrobial use by as much as 36% in hospitals in the United States. Although many countries have begun to adopt and promote antimicrobial stewardship policies and practices, these programs are largely absent from health facilities in GCC countries. Okay. So antimicrobial stewardship programs are antimicrobial management programs and a marriage of infection control and antimicrobial management, an activity that promotes an appropriate selection of antimicrobials, appropriate dosing of antimicrobials, and appropriate route and duration of antimicrobial therapy. And the combination of effective antimicrobial stewardship with comprehensive infection control programs has been shown to limit the emergence of transmission of antimicrobial resistant bacteria. The second goal of antimicrobial stewardship is to reduce the healthcare costs without adversely impacting quality of care. Okay. The potential active core of strategies, prospective audit with, like Dr. Nadwani mentioned, with intervention and feedback that can result in reduced inappropriate use. Okay. Formularies restriction and pre-authorization can lead to significant and immediate reduction in antimicrobial use and cost. And evidence-based interventions for antimicrobial resistance, guidelines, clinical pathways, and dose optimization, IV to PO switch, de-escalation therapy, education, antimicrobial order forms, antimicrobial cycling. It's been discussed probably yesterday and the day before, so I'm not going to discuss that. ID clinical pharmacist perspective, that's why we really push for education for all clinical pharmacists to go through ID training, and they will allow focus on drug classes and also need to assure appropriate antimicrobial management and safety, and assist in educational efforts, assist with formulary standardization and cost, and they would help in controlling cost. Okay. This is a study that I'm not really going to, but I'd like to just to show it to you. This is two of the speakers here are part of the study, and it compares practices in the States compared to UK and France, and legislation of antimicrobial stewardship programs. And I'd like everyone to just to look at it. I'm not going to go over. This is a study that was published by Dr. Balkhi at King Abdulaziz Medical City in Riyadh, Saudi Arabia. And she looked into the prevalence of antimicrobial resistant clinical isolates of Gulf Cooperation Council countries. And there are not much studies in the Gulf countries to look at. The majority of patients were from Saudi Arabia, and isolates from Saudi Arabia, and from the majority from Kuwait. Okay, and most of the isolates from were either E. coli, Klebsiella pneumonia, or resistant isolates, E. coli, Klebsiella pneumonia, and Acinetobacter Pseudomonas aeruginosa, which is not really a surprise, because that's what we see on daily basis. And this is a study that was mentioned by Dr. Hayal Abdali yesterday. I'm not going to really to look at, but I'd like everyone to read from Hussam Zawawi. And it's a very nice study. This is a study that was published in Jordan. Okay, it was published in 2013, and this is an evidence-based antimicrobial stewardship initiatives in Georgia improve antiprophylaxis for cesarean section. Before they conduct the study, the Jordan FDA found antimicrobial use prophylaxis, just like we mentioned, during common surgical procedures like C-section, were frequently administered inconsistently or inappropriate. So for that reason, the systems for improved access to pharmaceutical and services, which is part of the WHO, they provided technical assistance to 3 hospitals in Jordan to strengthen antibiotic prophylaxis practice for C-section. The results of all the 3 hospitals indicate good compliance to the protocols and procedures as measured by the use of the preferred prophylactic antibiotic, which is cefazolin, and the timing of administration and the number of doses administered. And the average surgical site infection rate dropped to 1.5% within international, which is within international rates. The average cost of antibiotic prophylaxis per case decreased by 79%. The hospitals experienced cost saving of approximately 10,905 Jordanian dinars, which is like $15,397 in 2012. And if you look at this, before they implement their program, okay, in 2012, the correct antibiotic use almost 0, and 2012, 86%. Correct timing of first dose improved to 92%, and correct number of doses, a single dose, except for pre-identified exceptions, is improved to 88% from almost 0. Okay. Based on the result of this study, the antibiotic prophylaxis protocol for C-section developed and mandated for all Ministry of Health hospitals in Jordan that were providing OB/GYN services, and initiation of similar programs by other hospitals not included in the initial pilot, and expansion of other surgical procedures like hernia. Now to move to our experience, which is very old experience in our institute, King Faisal Specialist Hospital in Riyadh. The AUE, which is antimicrobial subcommittee, it was established in King Faisal Specialist Hospital in 1994. The aim of the AUE mainly is to promote optimal antimicrobial therapy, prevent antimicrobial-related complications, evaluate the effectiveness of antimicrobial therapy, and improve patient care and establish interdisciplinary consensus on antimicrobial use process. Antimicrobial stewardship program is the systematic coordinated implementation of the policies of the AUE. We'll come to that later on. Okay, this is also this is a study that was, I believe this is the first study to publish in the region on antimicrobial stewardship. It was published in the Annals of Saudi Medicine 2012. And that study, we looked into the antimicrobial stewardship program implementation in medical ICU in our institution. And the primary objective is to look into the appropriateness of rate of empirical antibiotic therapy, and the secondary objective is to look into the C. diff rates in our ICU, and to look in the frequency of MDR, including MRSA and also ESBL. And also to look into the primary acceptance of our colleagues for the ASB recommendations, if they would accept that or not. Okay. If you look at the study results here, hospitalization by more than 5 days is better. There's no pointer here. It's 85% in hysterical control compared to 62% on ASB active patients. Hysterical control, we compared our ASB patients to hysterical patients before implementation of ASB in ICU. And also, broad spectrum antibiotics, it was 85% compared to in hysterical control compared to 25% only for ASB active patients. And also, and for steroid use more than 2 days, it's 83% compared to 37.5% for ASB patients. So if you look at the initial appropriateness, okay, there were no difference between, it was, the p-value is 0.379 between appropriate and inappropriate. However, if the final appropriateness, okay, which is defined, it was assessed following SV and team interventions, and you can see that 100% or 24 patients compared to 15 patients of the control, which is only 30 patients were using antibiotics appropriately, and 69% of the patients, they were using antibiotics inappropriate. And the reason for initial antibiotic inappropriateness and no current treatment of positive culture, it was 9 on control group compared to almost 0. No indications or colonization for current treatment, it was 5 compared to almost 0. And inadequate empiric coverage of, for indication, 14 in the control group compared to 10. And also excessive empiric coverage for indication, it was not really different between the two groups. And resistant to current antibiotic, it was like 12 in the control group compared to 1. And regimen excessive failure to de-escalate, it was 8 in the control group before implementing the ASB compared to 0. And regimen inadequate wrong dose or frequency, it was 10 in the control group compared to 6 in the control group compared to 10 and at the ASB group. And the interventions made in the active ASP team to overcome inappropriateness, it was like 89% regimen optimization, and followed by 21% change to broader spectrum antibiotic, and change to drug of choice, which is more effective and narrower, 10%, and discontinue unnecessary antimicrobial therapy was like 10%. Secondary outcomes for the study, C. diff was 2% in the control group compared to almost 0% after implementation of the ASB. Microbiological outcomes like MDR, it was 30% compared to only 8% in the ASB group. MRSA, it was 4% compared to almost less than, almost zero in the ASB group. ESBL, it was 2% compared to 0. MRSA, MDR, and patients in ICU course decreased number. It was 16% compared to 32%. And transferred to the floor, 59% compared to 83%. So 83% they were transferred to the floor of the ASB group compared to 59%. And transferred to another hospital, which is, the number is very low here, and still active in ICU, 6% in the hysterical group. And this is the direct cost of antibiotic utilization per patient in both groups. You can see here the average cost of hysterical control is much higher than the average cost of ASB arm. And also, this is post-hoc analysis showed the ASB implementation resulted in average cost reduction by 125 Saudi riyals as compared to hysterical group. This has been discussed by Dr. Nadwani, so I'm not going to look at. But we can say here, if you want to do an ASB, it should be tailored to your institution. Most of the institutions in our region, in our country, let's say, they don't have ASB, okay, but they have the elements to do ASB. Okay, so with the help from let's say administration, you can at least start by implementation. Okay, so you don't have to have ASB program, okay, ahead of time to say that, okay, I will do, and if I don't have ASB program, I'm not gonna do what I'm supposed to do. Okay. This is the barriers for establishing ASBs, lack of funding. This has been discussed a lot, I'm sure, in this meeting. Lack of funding, and this is one of the main reasons for not really having, okay, ASB program, because let's say ID or let's say clinical pharmacy, they would say, okay, we cannot do this because it's costly. Okay, it's too much. I cannot do this unless I'm supported. Higher administration, they cannot do this. They cannot support for funding. Okay, and shortage of adequate trained ID physicians, ID pharmacists. This is something. If there is no ID clinical pharmacists, ID trained physicians, especially ID clinical pharmacists, you can train, just like in MAD ID, yesterday Dr. Mashira mentioned, okay, you just train your clinical pharmacists. And lack of pharmacy leadership supporting, this is crucial, okay, if there is no support from, 2 minutes, okay. If there is no support from pharmacy for the clinical pharmacist, he cannot really do it. Okay, and Also, lack of infectious disease support. Okay, if the infectious disease team say, okay, we cannot really do this because, okay, we are very busy. Okay, the program will, most of the cases will fail. And competition of funding with other hospital programs. If you want to say, do an ASB program, okay, they go to the higher administration, they would say, okay, there are other programs that is more important than your ASB program. So it's better to do like what we have done, ASB study, just to show to the higher administration that we saved money, okay, and also we reduced the emergence of resistance in our institution. And communications with antagonizing colleagues, like probably an ICU and ID. ICU would like to do the ASB program, and ID would like to do the ASB program. It's better to work together and with pharmacy. Thank you.